Say there are 3 things you don't talk about in polite company.
And we just made a podcast about all of them.
Politics, religion, sex, and a few other things that'll get you uninvited from Thanksgiving dinner.
So grab a drink, loosen your belt, maybe hide this one from your boss.
Welcome to the Unmentionables. Hey everyone, I'm Evan, the guy with way too many questions and just enough nerve to ask them.
And I'm Melissa, therapist, mom, and here to answer those questions before the arguments start.
So here's how it works. I bring the curiosity, the wait, why is that a thing energy, and Melissa keeps us from setting the whole conversation on fire.
Most of the time.
I'm Evan. This is the Unmentionables. We're in the midst of the Lindsay Clancy trial that is sweeping the nation. My co-host, Melissa Smith, is a licensed clinical social worker, trauma certified, EMDR certified, all the certifications.
All the certifications.
And the executive director of a counseling practice. She's been reading and watching this trial the way a clinician reads it, which is very different from how it's being covered. You're going to get a lot of coverage about the law and the legal side of things, but Melissa's looking at it from a little bit different angle. Now, fair warning, we are going to discuss things like suicide, infant death, and severe postpartum mental illness. So if you're in a hard place right now, take care of yourself. I want to start with talking a little bit about the basics of the case. I want to start with the family. Lindsay and Patrick Clancy in Duxbury, Massachusetts, a coastal town south of Boston. 3 kids, Cora, 5 years old, Dawson, 3 years old, and Callan, just 8 months. Lindsay is a labor and delivery nurse. She had spent her career in the room with mothers throughout the process. Callan was born in May of 2022. By her husband's testimony, the trouble surfaced as she prepared to go back to work. She had a hard time being apart from the kids and especially the new baby. Let me give you a little bit about the timeline here. September 2022, her first appointment with Dr. Jennifer Tufts, who is telehealth at a practice called Astor Mental Health. October 3rd, initial therapy assessment with Jennifer McAllister, a licensed mental health counselor at the same practice. October 31st, another therapy appointment, days after she told her psychiatrist that she was afraid of thoughts about killing herself. We'll come back to this one. November, a second psychiatric nurse practitioner, Julie Paul, and then the South Shore Hospital's perinatal. She's at the South Shore Hospital's perinatal behavioral health clinic. Easy for me to say. Mm-hmm. And then also nurse practitioner Rebecca Gelada. We'll get into them as well. December 2nd, she had an intake with Letitia Dukes, a mental health counselor at the perinatal clinic. She saw her 4 times. Mid-December, the whole crisis. There's a hotline call, an emergency department visit, not admitted. Her Edinburgh postpartum depression score was 21, which I understand is quite severe. And I think Melissa will talk a little bit about that as we go through this. In early January, voluntary inpatient admission at McLean Hospital, discharged shortly after on a short stay. January 16th, a new medication added. January 23rd, an appointment with her psychiatrist. She was depressed, flat, numb for 17 days, no hospitalization recommended. January 24th, her husband leaves to pick up takeout and a prescription. He's gone for just a handful of minutes, maybe 10 to 15, and that's when the tragedy occurs. I want to talk a little bit about the medications. She was prescribed 13 psychiatric medications in 4 months. More than 30 prescriptions between September and January. Zoloft, Ativan, Klonopin, Valium, Seroquel, Trazodone, Buspirone, hydroxyzine, Lamictal, amitriptyline, and others that were discussed and considered during the trial and during her encounter. They were prescribed by psychiatrists and nurse practitioners, by emergency room physicians, by inpatient staff. There were several duplicate prescriptions days apart from different providers. Her psychiatrist testified she never had access to the complete medical record. Nobody had the whole picture here. And then on January 24th, 2023, Lindsay Clancy killed Cora, Dawson, and Callan. She then attempted to end her own life, but survived, paralyzed from the waist down. We're not going to go into all the hows and the legal stuff. I'll leave that for people like Emily D. Baker and the others that are probably going to go through this trial from a legal perspective. But what we are going to talk about is the clinical side of things and the system that was involved around her. She's charged with 3 counts of murder. She has not disputed that she killed her children. Her defense is that she was not criminally responsible.
She does not remember.
Correct. She doesn't remember.
So I think it's important to note here, actually, that she is not saying, I remember killing my children. She's not disputing that she did it and is saying, I don't remember this.
Correct. Now, the Commonwealth hasn't rested their case yet. The defense hasn't called a signal witness, so we will be revisiting this in a future episode. But 12 days of testimony are on record, most of them being prescribers, evaluators, investigators, a medical examiner. And Melissa's been watching for some specific things in all of it. So, Melissa, what are you not seeing?
I have been having a very hard time watching this for sure, because I know best practice, I know small practice, and I think it's abundantly clear that this is a large organization with what should be high oversight, and it would seem a lot of people not doing their jobs. This is a woman, and I know this is a super controversial issue. There's a lot of people who will sit here and say, but she killed her kids. And I look at this and go, yeah, and she was begging for help. She was begging to go inpatient and was denied because she was over-medicated. Yeah. I think that that's such an important thing to point out. And even in some of the stuff that we were watching last night, this is somebody who did not want to take medications. She was resistant to what side effects it would have, what complications she would have. Would she be a functional parent? And when you hear it took her, I think it was 2 months to agree to take Zoloft, and she had side effects. Now, the psychiatrist can't tell us what those side effects were. I don't know if the psychiatrist asked what they were. She could tell us the general side effects that many people that take Zoloft have, but not any specific to Lindsay. And this is the person who was responsible for overseeing the entire case. I have significant questions about the licensure level of the people who were treating her. Are they licensed to independently practice, or are they licensed to practice in a supervised fashion? Because we have a psychiatrist that's supervising the whole thing, I question what level of supervision that was. Were we just signing off on things because I have to sign off on them? Or were we actually reading things? Because if she was actually reading the documentation that she had available to her, this whole situation was avoidable.
Yeah, I mean, there's so many questions that we're going to go through on this episode. So if you are a case watcher, or if you're interested in mental health, or if this has touched you in some individual way, stay tuned, because we're going to go through a lot of this stuff.
And I also do want to point out, prenatal, postnatal, perinatal is not my area of specialty. So I am not speaking about all of this in regard specifically to how things were done in that setting. I'm looking at things from the external clinician standpoint and what is general best practice. What questions should we have been asking? What follow through should there have been? Where should higher levels of recommendation been made or been advocated more strongly for? Where should there have been communication? We're talking about risk of harm. Was she a risk of harm to those kids? And we have a duty then to discuss that with the husband or the police even. And getting started on the whole Patrick piece is a whole separate issue, because he's the one that left her alone with the kids, knowing how poorly she was doing.
Yeah, and that's a great point. We are going to get into that a little bit, because he was a part of some of the therapy sessions, and then also some of the discussions with the doctors about the medications.
Well, he wanted to meet with a psychiatrist and to be on the same page.
Correct. And also was one of the people advocating that she's different now that she's on the medication. Things are getting worse. And so, yeah.
But also left her alone with the kids.
Agreed. There's a lot of inconsistencies there. And I think there's a lot of points where during the trial, the judge has looked and gone, that's weird. It's not normal to him as a judge, a lay person, and not in the medical field. Now, you have stated this a couple times, and I want to make sure that I am clear for the listeners, but you are not a doctor.
I am not a medical doctor.
But I have heard you speak with doctors in relation to our kids, for example, and I'm always struck by how aligned you are with the understanding of the brain, how it functions, and how medications affect it. And I know that as a professional, you've done your own self-study on how medications affect the brain and the body.
I also work with a lot of different psychiatrists and take the time to learn and understand. And while I am not a doctor, I cannot write for medications. I cannot give advice on medications. We're the ones as clinicians that are seeing these people week in and week out. We're seeing the shifts and the changes. And oftentimes the medical community does devalue the input that we have and the thoughts that we have that would guide medication. The trend is they're a doctor. They know what they're doing.
Yeah.
We're not.
Yeah.
So we should stay in our own lane.
Yeah, and we're going to come back to that because I think there's a totality of care here that is this case is highlighting how little that totality of care is really
We call it
valued.
coordination of care.
Coordination of care.
Sure.
So I don't necessarily want you to comment specifically on the competence of the psychiatrist because I know you're not a doctor, though you might. But in general, psychiatrists and therapists have different roles, right? We just kind of talked about that.
Well, and it was very upsetting actually to hear Dr. Tufts or Tufts?
It's Tufts, Dr. Jennifer Tufts.
Is there a second T in that, or is it two Fs?
Tuft. Yeah, like the university.
So, right? Yeah, I was actually very frustrated. That was one of those points where I went, what the hell are you thinking or talking about? Because she's trying to skirt around a couple issues here. There are some psychiatrists who are duly trained in psychology, clinical work. And they bill for 45, 60-minute sessions. The fact that she sat there and her documentation shows it was a 17-minute session. And she wanted to try to say, oh, well, she billed for 25 minutes. And that 17 was the therapy portion. This woman doesn't do therapy.
Right.
She looks at medications. Somebody goes to a psychiatrist to be prescribed medications. And you meet with the psychiatrist for actually what is a standard 15-minute appointment.
Right.
You talk about, are the medications working? Are there symptoms where I need more support from a medication? And what are we going to change up? Out the door, move on, next client.
Right.
There is no deep CBT, DBT, EMDR work, somatic work. This is why she referred for a clinician to work with this woman on a weekly basis. So the fact that she is trying to say that she somehow is doing therapeutic work is so wild to me. And it shows the lack of recognition really of what her lane is. She is there to prescribe medications.
Right.
Period.
Right. Now obviously you have strong opinions. So,
well, the fact that she calls herself an expert too.
So
we'll get there.
I want to stay on this because I think it's interesting. She diagnosed Lindsay with generalized anxiety disorder, which I think you and I discussed as like, that's literally everyone that comes into the office.
It's actually not. So everybody that comes into the office pretty much has some kind of adjustment disorder. They're adjusting to something.
Yes, you did include adjustment disorder with depressed mood.
It's actually far more rare to have somebody that actually meets criteria for something like generalized anxiety disorder, major depressive disorder, even post-traumatic stress disorder. You can have some trauma and have more of an acute stress disorder. But to legitimately meet criteria as it is in the DSM presently is more rare. And she knew Lindsay was coming in because she was struggling since she had a baby.
Right. Now, interesting side note, you brought up the DSM.
Correct.
But psychiatrists don't really use the DSM,
They use
they?
the ICD-10. That's correct.
Is it the same document but with different names, or are there?
It's not.
Okay.
So the ICD-10 includes all medical diagnoses. I broke my finger. I have diabetes. It includes all of that.
Okay, so it's the doctor part of why they're a doctor.
Correct. The DSM is for mental health.
Okay.
So we do not have the vast, I mean, our book is probably that big. The ICD-10 is
Much bigger.
Much
Probably a volume set or something
more
like that.
exhaustive. Ours is specialized for us. So there are places where what the DSM calls a diagnosis, the ICD-10 actually calls something different.
Okay.
It's a medicalized term for the same diagnosis.
Okay.
There are places where we just recognize things differently.
Sure. Well,
Because they
it's
come from a
understandable.
medical perspective and we come from a person and environment perspective. We look at things more holistically, which is also often, I do want to give credit where credit is due. Nurse practitioners tend to also be a little more holistic, but we'll get into that as we...
We are actually going right to nurse practitioners. We are going to come back to the coordination of care and some of the differences because you've touched on a few things, the CBT, DBT, EMDR that some of the listeners and the viewers may not be familiar with or aware of. And I want you to, go into a little bit more detail about why those things are important.
Well, we don't
how
want
they
Miss
get
Dukes to
used.
feel left out.
We are going to cover Miss Dukes.
Do not want her to feel left out of this.
Now, I want, on this topic of nurse practitioners, I want to start with, I'm not throwing shade at nurses here from my perspective.
Not at all.
Nurses are absolutely essential to healthcare, and some nurse practitioners have an enormous amount of experience, especially in the psychiatric field.
And they're wildly important.
But I have to admit, from my perspective, and this is my perspective, not Melissa's. Melissa could speak for herself. But I have to admit, I feel uncomfortable with how much prescribing authority we've handed to psychiatric nurse practitioners. And here's where that discomfort really comes from. We're not talking about antibiotics for an ear infection here. We're talking about medications that can alter mood, cognition, sleep, anxiety, impulse control, emotional regulation. These are medications that are acting directly on the brain.
Correct.
And you're going to talk about just how powerful those effects can be. At the same time, when I look at the educational pathways that a psychiatric doctor takes versus a nurse practitioner, there's a pretty dramatic difference between them. A psychiatrist goes through medical school. You talked about this a minute ago. They have a 4-year psychiatric residency, years of supervised exposure to complicated psychiatric disease.
Correct.
They understand medication management, differential diagnosis, medical conditions that can look psychiatric, drug interactions, crisis situation, inpatient psychiatry, and so forth.
I'm going to totally jump in on this, though, because I'm biting my tongue. This is why nurse practitioners are not licensed to practice independently.
Right.
They require the supervision of a psychiatrist.
Right. And a psychiatric NP can absolutely become highly experienced and have some decades of
But a psychiatrist still has to sign off on what they're doing.
Yes, exactly. They have all this experience, but that level of experience isn't necessarily built into the minimum credential in the same way that psychiatrists do. So to your point, they still have to be signed off by someone
So
who's a
who was
psychiatrist.
looking at this stuff?
And so here's what I'm wrestling with, right? We have created a system where the authority to prescribe some incredibly powerful psychiatric medications can sometimes outpace the depth of medical and psychiatric training required to prescribe them.
You know what I think about here too is primary care doctor is an MD or DO.
Yeah.
These are meds, at least around here, they won't prescribe.
Yes.
They will refer to a psychiatrist that specializes. So they would prescribe the Zoloft. We talked about this the other day.
Yeah.
They would prescribe the Zoloft or the Ritalin, that kind of stuff. At the same time, they recognize this is outside my specialty. I need a psychiatrist. And then they'll often take back over care management when things are stabilized.
Sure.
But I'm asking myself, how the hell did this nurse practitioner...
2 of them, by the way, Gelada and Paul.
not say, this case is really complicated. I need help.
And that's a great segue to my next question, right? Which is going to be, when does a case become, you've talked about the primary care physicians, PCPs, referring to psychiatrists. When does a case become complicated enough that medication management really ought to be driven by a psychiatrist rather than a nurse practitioner?
Well, again, I'm not the medical professional, but I would think when we're talking about suicidality or homicidal ideations or somebody who, honestly, when you've tried a few things and you're not getting anywhere,
yeah,
why are we still shooting darts at a dartboard and not saying this needs a higher level? And quite honestly, as a clinician who is licensed to independently practice, I still seek out supervision. I still seek out consultation when I have a case that feels complicated and say, what am I missing here?
Yeah.
So why didn't they do that? Blows my mind, because if nothing else, you should be considering the fact that this is your license on the line.
I mean, I agree with you. There's a couple things here that are coming to mind as well. So, and this is interesting about this case, and I would like your take on it. So we talked about the importance of the psychiatrist in this. We've talked about the nurse practitioners and the potential for them to be maybe under-credentialed or under-experienced or just have a limited fund of knowledge.
Oh, that term too.
But
well, it's not that they are underexperienced or undertrained or anything for their role.
Sure.
It's that in a large setting like that, they are pushed to go outside of what their role should be.
Yeah.
Because it's more money in the door.
Yeah.
More people seen, more money in the door.
Yeah, and you touched on something earlier when you said this is not my area of expertise, talking about the perinatal, postnatal, prenatal services. Well, let me just touch a little bit on the certifications of these nurse practitioners that they did have. So Gelada, the primary nurse practitioner who took over for Paul because Paul moved on to a different role.
Oh, I thought Paul was at a different practice and was a secondary consultation.
No, Julie Paul was the referral from the mother-in-law. And then she moved into another role and couldn't provide that level of care to Lindsay, so she pushed her over to Gelada. But I want to get into these certifications because they're interesting. Gelada is PSI certified in perinatal mental health and had treated postpartum psychosis before. Julie Paul is board certified as a PMHNP and a certified nurse midwife who built the program at South Shore Hospital.
And that's different than Astor, right?
Yes. Astor is where Tufts and the therapist, Letitia Dukes were. And Letitia Dukes and Aaliyah Goodhart, who was the psychiatrist at the mental health of McLean Hospital where she went for the inpatient stay, neither of them had ever seen postpartum psychosis cases.
I do think it's important to note too here, and we are going to jump into where you're headed. We're talking about two different organizations too.
Correct.
And care going on from both at the same time.
Yeah. Yeah. That's again a place where I feel like the complicated structure of this, who's paying attention to all of it, right? Because you've got a patient with severe insomnia, suicidal thinking, possible bipolar symptoms, multiple psychiatric medications being started and stopped, multiple prescribers, questions about side effects, worries, anxiety about side effects, a rapidly changing clinical picture. Every time she takes a new medication, there's some new thing going on. And that's not to say she's done anything wrong, being the patient. She's reporting what she's feeling.
Have we figured out if Astor is connected to South Shore?
I think they may be in the same area, but Astor Mental Health is like the clinic, the place where she was trying to go for regular assistance. And South Shore was like the crisis hospital, ER, emergency room that they went to.
So Gelada
Yes.
was more of the crisis provider.
Correct.
That was not coordinating care with the regular provider.
Yes, and we actually got something wrong, and I want to back up and clear it up. So Tufts referred her to Jennifer
McLean.
No. It wasn't McLean. It was
McAllister.
Jennifer McAllister inside the Astor practice. The reason why we've got this wrong is that the prosecution has not yet called Jennifer McAllister to testify.
Correct.
Gelada and Paul at South Shore Hospital work with Letitia Dukes. So she's the crisis counselor.
That was trying to get her in with a therapist when she already had one. Because that was in December.
Dukes was trying to get her into the Women and Infants program so that she would have a day place to go with her baby.
I thought she also referred for outpatient. When apparently she already had an outpatient therapist.
She's referring everywhere.
She is. Because she said at one point that she was the like crossover care.
Yes, the crossover care. At what point do you say, like, this has exceeded routine medication management and we need a physician specialist in the room rather than a nurse practitioner and a crisis counselor? Mm-hmm. And is our mental health system actually designed to make that escalation happen? Or have we normalized psychiatric NPs functioning as substitutes for psychiatrists because psychiatrists are expensive and scarce and difficult to access?
It's hard to get. They're difficult to access. Because of complexity of care,
right?
It is so hard, at least in our area. You could wait a year to get in with a psychiatrist.
Yeah.
And so people are going to other places. And this is where mistakes happen.
Yeah. Yeah.
There's no continuity.
I'm at a place where, it feels to me, again, I'm a lay person. I'm a technologist and a business guy. I'm not a clinical operator, but
sure.
I just see doctor after doctor after doctor throwing meds at this woman who is begging them to help her get off the meds because of their side effects. And I know psychiatrists are the med people, but shouldn't they, I don't know, be more careful?
Well, and believe me, I understand our hospitals these days are very anti-keeping people. Right? It's not an emergency. So out the door you go, here's some drugs. And yet, when this person is
my own thoughts on too. But.
Same. But when this person is coming back repeatedly to your facility, your hospital, saying nothing is working, I am deteriorating, how are you not putting her in an inpatient setting if for no other reason than to keep her for 2 weeks and figure the meds out?
Yeah. I mean, we've seen that. Personally, we've seen that.
We have seen this happen.
So I don't know. I don't understand why it's not done, especially when you're dealing with a mother with young children. It's wild to me.
Because nobody actually cared about the safety of those kids. That's why.
Yeah. So we've spent a lot of
Lindsay.
Right.
Except Lindsay.
Which might sound interesting to you, but as if you go through the trial and as you look at some of the evidence and as we talk about things here, you'll understand that she was actually advocating for herself and for her kids.
She tried.
She wasn't being heard.
She tried.
We have talked a lot about meds, and we're going to hear a lot about meds whenever we talk about mental health.
Right.
Lindsay Clancy was prescribed 13 different medications and multiple combinations over the course of 5 months from September of 22 through January of 2023.
4 months.
There's a lot of focus on the psychiatrists. I know that we can't go into all the individual medications, but suffice to say, of the medications that I listed earlier, a lot of them are very powerful medications.
Those are heavy.
I think we talked about at least one or two of them being a step below lithium at this point. We're very close to.
I mean, we're talking serious, don't drive on these.
Right.
Extreme drowsiness, lethargy.
Yeah.
Mood issues.
And people are asking, well, why is she doing telehealth appointments? Well, because she's got 3 kids and she can't drive because she can barely walk and function, right?
Right.
Yeah, I get that.
She's becoming a zombie.
But meds are really just one part of the treatment process, right?
Correct.
We've spent a lot of time so far talking about psychiatrists, and honestly, we've barely scratched the surface of that discussion because there were so many involved in Lindsay's treatment. But I want to shift gears to the therapists that were involved in Lindsay's treatment, if you can call it that.
Well, we only know about one so far.
I'm a little skeptical here. We heard in Dr. Tuff's testimony that Lindsay was referred to a therapist who was then practicing inside of Astor Mental Health practice.
Right.
That's Jennifer McAllister. Interestingly, she is yet to be called to testify in the proceedings by the prosecution.
Which does tell me a lot.
Frankly, I would have expected that to have happened by now. And so if they were planning to have her testify some of her records were already discussed. I would have thought that she would have been called in order
Through the course
after
of
that,
Jennifer
through the
Tufts.
course of that, right?
Yeah.
Jennifer Tufts went over
The things that she was documenting
Sure.
were contradictive to the care that was being given by psychiatry.
Right.
It was very clear that she had not read the
quite
notes.
interesting to me. I found that odd, but I mean, unfortunately, we can't really get into too much around her because she hasn't testified yet. So, stay tuned for
But we can talk about Dukes.
Stay tuned for a future episode if and when she does testify to find out Melissa's thoughts on the clinical approach. That being said, we have heard, as you pointed out, from a counselor at South Shore Hospital perinatal program who met with Lindsay while she was working with Nurse Gelada and Nurse Paul. Her name's Letitia Dukes. Similar to Dr. Tufts, I know you have some strong feelings and thoughts about Letitia, a mental health counselor who testified as to her treatment of Lindsay during the month of December. So give us your take.
Well, I was texting you as I was watching her testimony.
Yes.
Going, what in the world is happening here? And so I'm going to overview my credentials real quick.
Yes.
I am a LCSW in the state of Pennsylvania. That is a licensed clinical social worker who has gone through the 3,000 hours of clinical work plus the supervision, and I am licensed to practice independently. Aside from that, I am a certified clinical trauma professional. I am a certified provider, not trained provider, in eye movement desensitization and reprocessing, or what we call EMDR. I am certified as a narcissistic abuse treatment clinician, and I am DOT SAP, substance abuse professional. I feel like I'm missing a credential in there, but I can't remember. And the reason that
she has a lot of letters at the end of her name, folks.
and that I don't typically point out to people, but here's why I'm pointing it out. Because in order to be certified in EMDR, I had to go through approximately 40 hours of EMDR specific training. It was in a small group. I think there were 15 of us. It included on-site practice that was supervised. On top of that, we had to complete, I believe it was 32 hours of trauma-specific training. We had to go through 10 hours of consultation on EMDR cases. I had to submit 2 recordings for review by my trainer. We had to read 2 additional books on EMDR practices. We are not talking about a short process.
Right. Is there a reason why that process is so long for the EMDR work?
Because we're messing with people's brains. We're messing with the wiring. And when it is done incorrectly, that is when there are concerns about introducing false information, leading people down bad paths. You can do serious harm to clients when they are not well prepared for that work, when they don't have the appropriate, we call them resourcing skills, but regulation. They're not prepared for the fallout that can happen after a session. If you don't keep them within the window of tolerance, they can just start to fall apart. And you're talking about major, major risks for that client. Now, what I see a lot in our area is everybody says they're trained. They're trained in EMDR. Well, what does training mean? Training could mean that you attended a 2-day, 12-hour training on what is EMDR. Well, now I'm trained and I'm going to go say that I do EMDR, but I don't know what I'm doing, but I don't even know that I don't know what I'm doing.
Right.
And I'm opening up things. And I get clients at my practice regularly that say, well, I did EMDR, but I don't think it worked, or I had a really bad response to it. And then I start to ask the questions. Mm-hmm. And you know what I find out? 9 times out of 10, they were trained.
They were trained clinicians.
They were minimally, incompetently trained and decided, I'm going to market myself as an expert. Mm-hmm. Which, wait a second, isn't that the same thing Jennifer Tufts said? She was an expert after she had spent a month there. That does not make you an expert. Then she tried to say, well, it depends on how you define an expert. Mm-hmm. Whole separate issue there. But that is why I want people to know, and this is just for everybody listening, If you are looking to do something that will mess with your brain, like EMDR, brain spotting is another one, find out the qualifications of that provider. Ask if they are trained or if they are certified and what that process looked like, because clients don't know.
Right.
They don't know that there's a difference. They don't know the questions to ask. It is our job. Part of it, they talked about informed consent.
Yes.
What is informed consent? It is part of informed consent that client understands what your qualifications are or are not and what it took to get those so that they understand the quality of care that they're getting. I don't know how I went off on that tangent, but I will let you refocus.
No, it's great that you went there because it's really important. And I'm going to go back to when we talk about EMDR, I'm assuming that's a process that you want to be well informed of your client about. It's something that you don't necessarily perform on visit one. It's not a short-term thing that you do.
It's very different if you're looking at somebody got into a car accident. It may be very short-term. We're talking maybe 6 sessions of EMDR work. It's very quick to prep for. Very, I hate to use the word easy, but very easy to implement and rewire the brain very quickly.
Right.
When we are talking about, again, not a postpartum professional, postpartum, though, is more complicated than a car accident.
Right.
And there's lots of hormones and neurotransmitters at play, not like a car accident. So when Letitia Dukes mentioned she saw Lindsay for 4 sessions, but did CBT, DBT, and EMDR all in 30-minute sessions. I went, what in the world are you doing and how incompetent are you? Because she could have opened something up unintentionally and made that entire situation worse. And why, as a crisis person, are you even touching EMDR?
Right.
Unless it's to very quickly try to bring somebody down, which again, if they don't have the resourcing, if they don't have the other, this woman was over medicated, and EMDR is contraindicated with clients that are on many of those meds.
Okay. Can you talk about what that means for the lay person who might be listening?
Sure. So if you're on medications like Seroquel, Lamictal, Remeron, the way they interact with your brain chemistry, the way they override things, prevents for us from accessing the areas of the brain that we need to do the EMDR work.
Right.
So unless she was using a basic tapping approach just to help Lindsay calm down and ground and re-regulate, but she never talked about that.
Sure.
She never explained how she was utilizing it, which leaves everybody questioning, everybody hopefully that has an EMDR certification, questioning what in the world were you doing?
I wanted to touch on that a little bit because I feel like we spent a lot of time in this trial listening to medications that were prescribed and when dosages were changed and all of those things. And that's certainly important. But what we didn't hear a lot of is the details around the therapy. We heard about timelines. We heard about the intake process in person, 1 hour. We heard telehealth, 30 minutes. Patrick was there. They talked about, the way she was feeling, and they talked about her medicine impacting. There's a lot of focus on these calls even about medicine, even though, Dukes can't handle medicine, right? She's like, okay, well, maybe she needs a higher level of care, which she
definitely did.
Yeah, fine.
And then she was turned away from it.
When she went to the higher level of care in women's and infants, she was turned away, to your point, because she was over medicated, they said. So
why didn't they hospitalize her to get off the meds so that she could go back to that program?
Right. So that there's that. But in addition to that, why do we spend and this is, if you've watched other trials that have involved mental health, I've been struck. Just there was was she in Colorado, the mom that killed the stepchild and then drove the body to Florida and disposed of it. There's been other killers along the way, Casey Anthony, all the rest of them, right? So when you look at these cases, there's a lot of focus on the medication, and fair point, right? Fair play. We've talked about how dangerous course it is. But what I don't hear in these cases is a real in-depth understanding of the therapy that's involved in it. And I think it's important that we spend a little bit of time on that, because we don't hear about it from the defense side or the prosecution side. What do they actually do when we talk about CBT, DBT, EMDR? What is actually going on in these sessions? What are you getting down to? And I think one of the things that you have surfaced in these views is like, okay, great. You say you did that on that date. What did you do?
What did you actually do?
What did you actually ask her? And when Letitia Dukes was being asked those questions by the defense, what did you actually ask her? I have to refer to my notes. If that's all you got is notes,
right,
one has to ask how invested you are in your clients.
Agreed.
And I've asked you, I've asked other clinicians at this practice, if something like this occurred, if you had a former patient who you had maybe recently helped, and I know we're in 2026 now, but I mean, this happened in 2023, and I feel like when it happened, anybody that was affiliated with her or had been, they're in the local area, wouldn't that turn you into like, let me go back to my notes and think about what I
did wrong? What did I miss?
Yeah, Heather said that the other day. What did I miss?
What did I miss? And I would be pouring through every interaction with that client going, where did I go wrong?
Yeah. I mean, you almost wouldn't even need your notes on the stand because you would know it, right?
Mm-hmm.
And
absolutely. It tells me that they're trying to cover their own asses. And as I understand, there's also another lawsuit by Patrick toward all of the providers for what they didn't do, how they did not help his wife.
Yeah.
I mean, we're talking like a multi-million-dollar lawsuit happening.
Yeah.
So my sense says they are in cover your ass mode.
Yeah.
And don't want to admit to anything they did or didn't do at this point. Because everything from this trial will be used in that civil suit. And
on the concept or the premise of, notes and what's in it, there's been several times where both psychiatrists and therapists throughout the case have talked about the client indicated. Right. And what we found
how did they indicate that?
The indication process, right, exactly, is they can't say whether she said it out loud, what words she used. Right. Fine, I get you don't remember conversations that happened 3 years ago necessarily, although, again, in this case, you might surface some of those things. But what we found out is the indication is actually happening on a medical form.
Right.
A screener.
Which different people interpret different ways.
Right.
And both on the client side and the clinician side.
And so as a clinician, somebody answers questions on a screener. Do you review those questions?
I do, and I ask questions about it.
Okay. So if somebody put down there, for example, that, they were able to smile and laugh now after a period of
say that's an improvement. Great. Can you tell me more about that?
Exactly.
Where, under what circumstances were you able to smile and laugh?
Right.
And what tends to happen is, oh, well, I don't know if I can think of any.
Right.
Or, well, my baby laughed for the first time and I smiled.
Mm-hmm.
But if we're not asking the question, are we thinking that it's happening like magically they're fixed?
Right.
I have a magic wand, apparently.
The meds worked.
The meds are magically working when they haven't been. And that's where it's like somebody took this one shred, didn't investigate it, and was like, okay, things are better now.
Right.
And they weren't. Nobody took the time to look into it. Now, I will say on behalf of Ms. Dukes, she's a crisis provider.
Mm-hmm.
They're not
that very different from a...
It is. We go in depth. They are much like the ER at the hospital. How do I try to make this woman safe and get her to a better level of care?
Okay.
She really is crisis. That's why they're 30-minute sessions. Actually, a lot of doctors' offices around here have a clinician on staff, but they're 30-minute appointments, and then they try to find you a regular clinician.
Yeah.
They're filling the gap, basically. What I don't understand, though, is the fact that she already had a clinician.
Yeah.
So what gap were we filling?
That's a great question. And without the testimony of that clinician, we don't really know, right? It's interesting.
Yeah.
So Dukes also testified that she saw no mania, delusions, paranoia, psychosis, and had no concerns about her physical well-being or the well-being of others in her presence. And one of the things that we were discussing this the other day had sort of brought up, and I'd like your thoughts on it. Is it, and I know psychiatrists call them patients, you call them clients, I'll just, call them people.
It's fine.
When people come into the office, do they always present exactly the way that their symptoms actually are?
They don't. And also, Duke saw her 4 times between December 2nd and December 19th. And this situation didn't happen until January 24th.
Right.
So there's a lot that could change in a month.
Especially with all those medications changing in that period.
Correct. So the fact that she didn't pick up on any of that, which as a crisis provider, I would think that she would be a little more adept at picking up on those things because she's looking for crisis-y kind of symptoms.
Yeah. So, and let me ask you this to sort of build on that, right? So everybody has said she never suggested that she was going to hurt herself or others. She answered this on the form. She answered that on the form. Are there times where you don't just take their word for it about whether they're having, if they're having, say, suicidal thoughts or suicidal ideations? Is there a time where you say, I have to dig deeper into this because she says she's not going to hurt herself or the kids. She says she doesn't have a plan, so I'm not going to refer her to inpatient. Inpatient. Is there a place or a time where you as a clinician go, I'm not taking your word for it? You've shown me too many signs that I think the inpatient is the referral I need to make.
I think there's 2 different pieces to this. Yes, we call those smoke cases, where there's so much smoke that that they're imminent risk of snapping. Mm-hmm. Yes, absolutely.
Even if they say, no, I don't have any plans.
The problem isn't us trying to get the person the care. The problem is the inpatient facilities that if the client is unwilling, we can't get them. We call it a 302 here in Pennsylvania. I think they call it a Section 12 up in Massachusetts. Yeah. But it's an involuntary commitment. Thank you. Mm-hmm. That's what I was looking for.
Yep.
It is very hard to get one, at least in our state. And unless somebody is expressing an active plan with intent, we won't get it.
Right.
And then we know that there are risks. And this is similar to what happened when the military guy was it was somewhere up north, Maine, Boston. I can't remember. It was a couple of years ago. That the guy,
the school shooter.
No, the guy in the military. The wife kept on telling everybody he's a risk. He's a risk. He's a risk. He needs more help. And then he went to the bowling alley and shot up her and everybody else. Mm-hmm. And it was a failure of the system because the question is, do we have the right to take away this person's freedom? Mm-hmm. Except in Lindsay's case, she was begging them. And that's the other piece of this is we want to say, well, she wasn't reporting these suicidal ideations or homicidal ideations or plan. And yet she was telling people from September that she had these thoughts and feelings and nobody is listening to her. And how long do we keep repeating ourselves without just going, what's the point?
Yeah.
Nobody believes me anyway. The vulnerability it takes as a mother to say, I am having these thoughts, and then to have somebody not believe you or downplay them or say, you don't get the help. I can't imagine.
Yeah. I can't help but wonder how much of this is the vacuum that we've created. And this is kind of where I want to go now. I want to talk about the cooperation between providers and treatment, right? I would like to think that professionals treating the same person would want to stay informed with their updated treatment of their patients and clients. But I know from talking with you that there are times when you need to start with fresh eyes. Can you walk me through the way an ideal holistic mental health treatment system looks? What does that look like?
Well, it depends on where it starts, right? So we've talked about the fact that if a client comes in to see me, I don't necessarily read all the intake paperwork.
Sure.
I know the gist of it because I want to get to know my client and build a relationship with my client before I go in and read through all of those things. If I have a client coming to me from a medical setting, I am darn well going to pour through that discharge summary and talk to the referring provider there before I even agree to take the client to make sure that it's a good fit and that it's within my wheelhouse.
Right. Dukes testifies she never reviewed Nurse Paul or Gelada's notes. Same clinic, same program, same patient.
Which in a crisis scenario makes zero sense.
Right.
Zero.
Well, on redirect, the prosecutor asked her why, and her answer was that she wanted a fresh set of eyes to assess the situation herself, and that this is typical practice.
But after session 1, you go read those notes then.
Okay. I was going to say make the case for fresh eyes.
You got your fresh eyes. Now you go read the notes.
Now you go back and read them, right?
And you coordinate with the other providers.
What did I miss that I didn't see, right?
Yep.
This patient had 4 active psychotropics and passive suicidal ideations. So that's at the point where, like you're saying, you go back and read what people are doing here, right? Like this.
And you say this is a risk. We're putting ourselves at risk. We're putting this mother at risk.
And I want to go into another topic here. And I know that clinicians, therapists, you're not prescribers, right?
Correct.
But
I feel like I'm on the stand. Correct.
But I have mentioned this, and I want, to sort of put this out there. I think good clinicians at least get a sense of the medicines that are out there and how they respond or correspond.
The psychotropics, yeah.
Especially the psychotropics, right? Dukes testified that the medication list in her notes is pre-filled by the clinical system, and she didn't know what was actually prescribed or what was active. And my question is that a sign of a good clinician versus bad clinician?
No, even in our first sessions, it's okay, what meds are you actively taking?
And so, yeah, so a clinician that doesn't know what you're on is
missing a huge piece of your puzzle,
right? Is there a version of this where you get a fresh assessment and then somebody still holds the whole record? There's somebody looking over this. That's what Tuff said. She said, I am in charge. The psychiatrist is in charge of the entire component here. Should not have the nurse practitioners been saying, okay, we see the therapy notes and we need to talk.
I want to know who was overseeing Gelada.
Yeah.
They haven't called her either, her or him, but she's a nurse practitioner. Who was overseeing her?
Yeah. So Tufts didn't obtain outside records and was unaware of the 2 crisis line contacts. Gelada never spoke with Tufts, didn't have her records, never contacted women's and infants.
Although, didn't somebody try to leave Gelada a message and Gelada never returned the call?
That was women and infants apparently called her.
Oh, and she never called
them back is what
to coordinate care
was testified to. Yes.
She never got a phone call, she said.
Right. Never obtained McLean's records after the inpatient stay while agreeing that the diagnosis and treatment would matter to her if she had gotten that. Dukes didn't know about the December 15th Mass General ER visit that the Clancys had. Dukes referred a patient who's already been referred 4 days earlier by an ER she'd never heard from to the same program. So there's 2 referrals, active referrals going on there, which I know not a lot about the clinical side, but I do know the operational side. When you see 2 versions of something, that's going to cause a delay because somebody's got to figure out which one counts.
Oh, I didn't even think about that.
Right. Dukes didn't know that women in influence concluded on December 20th that Lindsay didn't qualify.
Well, she didn't see her anymore after the 19th.
That it was didn't know that it was because of medication, being over medicated. You have 2 integrated teams with Astor on one side with a therapist and a psychiatrist. You have South Shore that has nurse practitioners / psychiatric nurses and therapists.
And you have a woman who's not stable. And somebody else should have been stepping in and advocating for her too, and making sure that coordination was happening.
Right.
That would have been her husband's role.
Right.
I don't know what he was doing.
But by all accounts in the testimony, he attended some of these telehealths and talked about the medications.
Right.
And, they can't tell you exactly what he said, although when we talked, you would have remembered what a third party that was invited to the meetings had
Especially
said.
If it was outside the norm.
Right, if it was not normal. What is a closed loop referral? Have you ever heard of that?
I haven't.
Okay. A patient voluntarily admits herself to an inpatient psychiatry.
Right.
Okay. Who obtains the discharge diagnosis and medication reconciliation before outpatient prescribing resumes? Like, who is there like
the facility should be setting up the discharge care,
because we know,
and then they should be sending the discharge resource, the discharge documents.
Right. Exactly. And that's kind of where I was going with this, is that somebody at McLean, right, had to know she was seeing Tufts.
Correct.
At least, if not also Gelada and
that would
everybody
have been
else.
the discharge resource.
And the discharge resource should have been sent the paperwork.
Correct.
And it's not on the patient to do that, right? We don't hand mentally ill people paperwork and say, make sure this gets delivered.
She would have needed to sign a release for all of that to be sent to Tufts. And I would think if McLean is competent, they would say, who's your provider? We need to set up aftercare. Can you sign this release? Because they're all saying she was able to do this stuff.
Right.
So sign the release here for us to send all of that so that they're up to date on things.
Right. At the top of this episode, I asked you whether psychiatrists and therapists have different roles. You said they do.
Absolutely.
In this case, did anybody have the role of holding the entire thing?
Well, they say the psychiatrist did, which lays a lot of liability on the psychiatrist's hands.
Mm-hmm. But
did anybody
we also
actually
have psychiatrists going,
right.
I didn't do it.
So no, nobody was actually coordinating this woman's care. And honestly, the average person, I mean, I've had to advocate for our kids a lot.
Yes.
And I'm a social worker, so I'm a trained advocate. And I can't imagine the average person trying to navigate these things. Now, I mean, one benefit Lindsay had is at least she somewhat knew the system. I mean, she knew the labor and delivery side of the system, not the mental health side of the system.
Sure.
But no person should have to advocate this hard for help.
Yeah.
And then we have outcomes like this.
So sad. One more question for you. What in this trial record, this, bubble that we've seen so far, what parts of this could have happened here in your practice?
Oh, well, we don't have psychiatry.
Fair.
And
you do
reasons.
work with psychiatrists.
We do, but there
outside.
are reasons that we don't have psychiatry here. We refer out and we keep things separate.
I'd love to hear your reasons.
Because it is, and you learned this when we were working on our paperwork for Medicaid.
Mm-hmm.
Psychiatrists, at least in Pennsylvania, have an unlimited number of unlicensed clinicians whose work they can supervise.
Yeah.
Unlimited. So
lots of things get mixed when you have that many.
Lots of things get missed. And it is a recipe for disaster.
Mm-hmm.
And it's my gut intuition that that's exactly what happened here. Is we have people supervising other staff and are just trusting them to do what they're supposed to do. And we're signing off on stuff. We are asking providers to do far too much in not enough time for not enough money. And it is sacrificing the quality for the quantity. And that's people's pockets.
Yeah.
And we refuse to do that here.
So aside from the psychiatrist piece, at Heart for Change,
we put quality above quantity.
None of the other misses would have happened, right? There wouldn't have been a lack of collaboration of care or coordination of care. There wouldn't have been untrained or uncertified people utilizing, modalities that they don't fully understand. Or
we're very strict on that.
Yeah.
We're strict on becoming an actual expert in your area.
Yeah.
And doing what you do and doing it really well and consulting with others that are also practicing in that area.
Yeah.
So we do a lot of consultation, a lot of supervision. We look at things from a lot of different angles, and we don't hesitate to say, what am I missing here? Let me get fresh eyes in here on it.
Excellence is mastery, and we're not afraid to ask questions, right?
Absolutely.
Okay.
So we would have reached out for additional help. And if we are seeing stuff like that, we're on the phone with that psychiatrist.
Yeah. And I think that's the difference, right? Is that there's active collaboration.
Or we're pushing harder for those inpatient stays.
Yeah. Well, the Commonwealth hasn't rested. The defense hasn't called a witness yet. Jennifer McAllister hasn't testified. There's a motion pending about a McLean social worker who says what the jury has heard about the hospital isn't true and wants to talk about that. There's been, some rumors that maybe the hospital's not all it's cracked up to be. It's not as great as they're suggesting it is. We'll be back when all that stuff plays out, but here's where we are after 12 days of trial. There's an enormous amount of mental health care in this case. There's almost no coordinated mental health care in this case. And everybody treated a piece of her, but nobody was treating the entire patient. For those of you who are listening that might be going through crisis, I want to give you some basic information here. The Postpartum Support International, or PSI, crisis line, 1-800-944-4773. The National Maternal Mental Health Hotline, 1-833-852-6262. 988 Suicide and Crisis Lifeline. These are resources, support that you can contact if you're ever in these kinds of situations. God forbid that ever be the case, but we want you safe. We want you secure. And
we want your kids safe.
We want your kids safe. We'll see you next time. This has been another episode of the Unmentionables podcast. Thank you so much for listening, and we hope that we have been able to share valuable perspectives that can help you in your own life. We want your feedback on future content. You can find us on the web at podcast.theunmentionablespod.com, where you can follow us and subscribe for subscriber-only content like the Equalizer series, where we break down topics with truth and analyze the narratives we hear today to decide what's really going on. You can reach out to us on the social media platforms, YouTube, Facebook, Instagram, and TikTok at The Unmentionables Podcast, on X at UnmentionablesX. Each episode also includes a text link in the description. And of course, if you follow us on your favorite podcast platform, you can send us comments and requests there. We're so grateful that you take the time to listen to us, and we want you to know that we appreciate your interest in what we do.